Hi guys. So I'm Luke Johnson. I'm an assistant professor at the University of Utah in the Department of Dermatology, coming to you live from my bedroom closet. I've got a new sort of sound setup here, so I hope it sounds okay. If it doesn't, then let me know. There's some audience participation, so you can start by directing your devices here, and then we'll do a little bit of a quiz. But first, I should let you know that I have no conflicts except that maybe this one. So I co-host a podcast about dermatology, and fair warning, I'm planning to release this very recording as a bonus episode. It's called Dermosphere. It's about the latest research in dermatology. So if you consider yourself dermatologically curious, then come check it out sometime. All right, and now let's move on to this quiz business. So hopefully this all works for you guys. So go to that address shown earlier. And oh, it might not work because Zoom takes a lot of bandwidth, so it doesn't like to load probably. All right, so instead of just standing here awkwardly, we'll just go down this way. I think you should still be able to answer it, even though this isn't full screen mode. So what is the most common cutaneous change in pregnancy? And if you can't get the website or whatever to work, just think to yourself and commit to an answer. Areolar hyperpigmentation, linea nigra, melasma, striae gravidarum, or something else. A couple comments in the chat. I'm not able to easily monitor them at the same time, so if somebody over there could volunteer to monitor the chat and let me know if there's anything I should know about, I would appreciate it. Okay, the next question is, what is the best treatment for Striae rubra? Is it CBD oil? There's nothing it can't do. Coconut oil, petroleum jelly, pulse dye laser, tretinoin cream, or nothing works? Next question, what's this? Those of you who are on the podcast, I apologize that you can't see the picture. But is it atopic eruption of pregnancy, intrahepatic cholestasis of pregnancy, Pemphigoid gestationis, polymorphic eruption of pregnancy, or pustular psoriasis of pregnancy? I'm going to move on in 5, 4, 3, 2.
I think we're just having trouble getting the link.
I don't think anybody's able to enter the questions yet.
Nobody's able to. Okay, well, just think to yourself and commit.
Okay, can we go back to them? Because I think we were all scrambling to try and look at get on this.
Well, I'm sorry it didn't work. Okay, well, we're going to start with what is the most common cutaneous change in pregnancy? Is it areolar hyperpigmentation? Is it linea nigra? Is it melasma, striae gravidarum, or something else? Think and commit, and I apologize for the technology glitch. All right, what is the best treatment for Striae rubra? Is it CBD oil, coconut oil, petroleum jelly, pulse dye laser, tretinoin cream, or nothing works? And take a look at this picture of a pregnant belly. What is it? Is it atopic eruption of pregnancy, intrahepatic cholestasis of pregnancy, Pemphigoid gestationis, polymorphic eruption of pregnancy, or pustular psoriasis of pregnancy? And which dermatosis or dermatoses can result in fetal demise? You can choose any that are appropriate. Atopic eruption of pregnancy, intrahepatic cholestasis of pregnancy, Pemphigoid gestationis, polymorphic eruption of pregnancy, or pustular psoriasis of pregnancy. Fetal demise, bad. And which has a risk of recurrence in future pregnancies? Same options. Okay, we will come back to these at the end of the presentation and come up with the right answers. But let's continue. We're going to start by talking about physiologic changes that piss people off. So our objectives for this portion are to identify the major physiologic cutaneous changes in pregnancy and discuss treatment and prevention. Of course, I'm happy to hear questions as they go along. I won't be able to look at the chat, so just feel free to chime in if you want. So why do you have all these physiologic changes during pregnancy? And look, there's a whole bunch of them. You guys obviously know way more about this than I do. I just focus on this tiny little area down here in the integumentary system, but I notice that there's a lot of other things going on. We don't exactly know why it happens, but it's thought to be related to several different things, including hormonal changes, vascular changes, changes to the immune system, and then soft tissue changes as well. So one of the largest studies I found about physiologic changes was this one. Came out in 2011 in the Indian Journal of Dermatology, Venereology, and Leprology. Whether or not it's 100% generalizable to our population is probably a little bit of a question, because these are Indian women for the most part, but still it was the largest study I could find on it. So I want to draw your attention here so you can see that areolar hyperpigmentation, super common, at least in their population, at 81%, whereas more than half of people also got linea nigra and melasma, and also striae gravidarum. Whereas some other things were not as common as I thought they would be. Like skin tags only show up in 3%. Edema, I thought just about everybody got edema, at least that's the impression I got after my wife's second pregnancy, but only about a quarter of pregnant people, turns out, get edema. And then varicosity is also not as common as I thought, only 3%. So when it comes to hyperpigmentation, this is a physiologic change that can be annoying to the patient. The areolae are the most commonly affected, followed by the axillae and then the vulva. Other things that can hyperpigment include scars and uncommonly nevi, though this is something that's discussed in the dermatology literature a little bit. The consensus seems to be that maybe nevi can change during pregnancy, but it doesn't give them a free ride. So any new or changing mole, probably still something we should look at, even if it's in a pregnant person. And then linea nigra, fairly common. And melasma, as I'm sure you guys know, is pretty common, especially in this population. So if somebody wants their hyperpigmentation treated, you can reassure them that most of the time it resolves postnatally. Tretinoin cream. Tretinoin cream is such a great medicine. It's on a short list of like 3 of my favorite medicines. It's good for acne, it's good for scars, it's good for wrinkles, and it's good for pigment changes. Basically, anybody who's not pregnant or breastfeeding should probably be using it. So if there's a hyperpigmentation problem, you can have your patient use it nightly. I tell patients that it can cause a little bit of skin irritation. So if it causes them to be a little bit dry and flaky, just back off for a day or 2, let your skin recover, and then come back to it. And if you want, you can say, and if you're using it every night with no irritation, let us know, and we'll increase the strength, because the highest strength you can tolerate will give you the best results. As far as medicines that actually directly lighten the skin, I prefer the term lightening agent to bleaching agent, because bleaching just sounds so harsh. Hydroquinone 4% cream is sort of the gold standard. Use it twice a day, and I have people use it for 10 weeks on and 2 weeks off. There's this concern that if it's used too much, that it can paradoxically darken the skin. It's called ochronosis. And then sun protection. Sun protection is really important because the sunlight can really fix that pigment in place. So especially with conditions like melasma, I tell patients, you can be doing all this cream stuff, and then if you're out in the sun for 1 day with no sun protection, that sets us back like a month or 2. So sun protection, hugely important for this hyperpigmentation stuff. So you gotta watch out for recurrence with oral contraceptive pills, especially if people get melasma. You guys probably know this already, but if you get melasma during pregnancy, there's an extra chance you'll get it when you're exposed to other exogenous hormones, or endogenous hormones, I guess, including OCPs. And of course, people who never had melasma during pregnancy can still get it with OCPs. So again, this sun protection business is important. I'm not sure I 100% love this slip, slop, slap, seek, slide approach, but this was a fun graphic online just to emphasize that sun protection means more than just putting on sunscreen. Though we do like sunscreen, as long as it's SPF 30 plus, that's a good idea. But there's also sun protective clothing, there's hats, there's staying in the shade. Sunglasses are helpful because especially it's hard to get sunscreen right around the eyes. So it's not just sunscreen, it's all of this stuff as well. Sun protection. Here's an example of linea nigra. It's this linear hyperpigmented patch extending, I guess, not transversely, longitudinally along the abdomen. Is that transverse or longitudinal? Don't know. I know mostly about fingernails when it comes to that. One of the tough things about doing this remotely is that I feel like I can't connect with the audience very much. You guys are probably like nodding your heads or shaking your heads or something.
We're all laughing.
Oh, good. That was my goal.
It's hitting home.
Here is some areolar hyperpigmentation. You can see that there's hyperpigmentation that even extends beyond the areola. So if that wasn't the case, you could maybe not know if this was hyperpigmented for this patient or not. But with this extra hyperpigmentation in areas that are not physiologic, it suggests that this is probably related to the pregnancy. Melasma. Melasma comes in various types. There's the central facial type, and then there's the perioral type, etc. It can also affect other parts of the body. I've seen it affect the forearms and so on. Super annoying, hard to treat, but not impossible to treat. There is hope. So that's the business with hyperpigmentation stuff. If anybody has questions about that, feel free to chime in. Otherwise, we're going to move on to striae gravidarum, stretch marks. People hate stretch marks. So this is one of the best articles I found about it from the American Journal of Obstetrics and Gynecology. Do you guys call it AJOG? Is this like one of the premier journals that gets a nickname? I like AJOG anyway.
Yes, it is.
Oh, good. So this is from 2007, and they had 112 women who had, this was their first pregnancy. I've learned that's what primiparous means. And what they have discovered is that the risk for developing striae at all is if you are younger, so average age of 26 was more likely to develop striae rather than average age of 30. And then increased weight gain. So if you gained 38 kilograms during your pregnancy, you are more likely to develop striae than if you would gain 15 kilograms during pregnancy. And just for reference, that's a low of 34 pounds versus a high of about 85 pounds. So those are the only things that they found were increased your risk of developing striae. But there are some other risks that if you do get stretch marks, they'll be worse. And that's if the baby is heavier, so higher birth weight, later in gestation, possibly related to the higher birth weight business, and also family history. So if your mom or your sister had bad stretch marks, the odds are that if you get stretch marks, they will be worse. Bummer. I guess you could wait until you're age 30 to have children, but I mean, just to avoid stretch marks, is that really worth it? So what doesn't matter? So there are a number of urban legends about what might influence the development of stretch marks. So fetal gender does not matter. Their socioeconomic status does not matter. Your skin type, as opposed to like light or dark skinned, doesn't matter. And also creams and stuff. So do not believe the internet, because there are all these creams that are marketed to help prevent stretch marks or to eliminate them once they show up. And as you can see, they're all marketed apparently to young Caucasian women who wear white underwear, and they don't work. I wish there was something that did work. I've looked into it. There's nothing that I found convincing. And you can see that they all have these fun graphics on them. I think this graphic right here on this product is a piece of clip art because I found it online and I'm using it in my own presentation. So this stuff doesn't work. Okay, we're going to move on to the specific pregnancy dermatoses in a second. If people are bothered by the red color of their stretch marks, though, the PDL laser, or pulse dye laser, can help take the red color away. The red color will fade away by itself, but if somebody's really annoyed by it and wants it to go away now, then you can use a PDL laser. Questions about any of the physiologic stuff? Okay, so the second part of this lecture is 2 people in 1, pregnancy dermatoses. So I'm a pediatric dermatologist by training, though I see kids and adults, so I like to joke that pregnancy dermatoses just combines both of my interests, because there's one tiny little person, and then there's one larger than she normally is person. And this graphic here, as you'll notice, same one that's on this product right here, has the little heart in the belly, because that's what we always like to think about. There's a little fetus in there growing happily, but sometimes that fetus and placenta has its own ideas about what it wants to do to that woman's skin. Mwahahaha. So during the objectives here will describe the 5. So one of the things that's nice about the pregnancy dermatoses is that they're kind of bite-sized. Just 5 things to remember. They'll discuss the risks associated with each, and we'll talk about how to treat them. So why does this happen? In some ways, they're similar to why we think some of the physiologic changes happen during pregnancy, especially the immune things. So there is a shift from a Th1 immune response to a Th2 prominent response during pregnancy. And that's especially true in the placenta. And that change is thought to increase the risk of autoimmune disease, and it's thought to decrease cell-mediated immunity. So cell-mediated immunity, of course, is when your immune cells are the ones that attack things and cause the issue. And that increases the pregnant woman's risk of skin infections. And also in dermatology, we learned that there are some diseases that are thought to be Th1 predominant, like psoriasis, and others that are thought to be Th2 predominant, like atopic dermatitis and lupus. So because there's a shift in the balance to more Th2 predominant, the Th1 diseases, like psoriasis, tend to get better, whereas the Th2 diseases tend to get a bit worse. Tend to. So when I was first learning about these, one of the reasons that I found it confusing was that there was a lot of nomenclature out there. And it turns out, at least according to the more recent re-nomenclaturization of these things, that a lot of it all kind of referred to the same thing. So there are now 5 pregnancy dermatoses: polymorphic eruption of pregnancy, atopic eruption of pregnancy, pemphigoid gestationis, intrahepatic cholestasis of pregnancy, and pustular psoriasis of pregnancy. All these other words that you see down here are not considered current nomenclature. So I won't mention them just because I don't want you to remember what they are, except that PUP, P-U-P-P-P, papular or peritic urticarial papules and plaques of pregnancy, is now on the outs. I'm sorry. I know there's a lot of people out there who love PUP, just like there are a lot of people out there who love Pluto and we're disappointed that it's not a planet anymore. But that's just the way it is as science advances, and I hope in time you will come to love polymorphic eruption of pregnancy, or PEP, even more than you have loved PUP. And that's the one we're going to talk about first. This picture of a pregnant belly is one of my friends from medical school who told me it was okay to use her photographs. She was very itchy. So polymorphic of pregnancy usually happens in prima gravids. It happens in the 3rd trimester, and it's more likely to happen with increased maternal weight gain. And if you have twins or more fetuses in there, then it also increases the risk. It begins in the striae, spares the umbilicus, so that's an important distinguishing feature compared to some of the other pregnancy dermatoses. And it's very itchy. Why exactly it happens, we don't know, but some people have postulated that maybe the stretching of the skin that causes the stretch marks reveals antigens that were previously hidden from the immune system. And now that the immune system can go after them, it makes people itchy. I don't know if that's true or not, but it helps me remember a lot of stuff about this, like the fact that it starts in the stretch marks and that there's an increased risk with basically increased baby, with more babies or with bigger babies. The good news is that there's no risks either to mom or to baby, except she gets driven crazy by the itching, and you can treat it with topical steroids. Anyone questions about polymorphic eruption of pregnancy? PEP. If you get a bunch of people with this condition together, it's a pep rally. I just made that up, believe it or not. We're going to talk about atopic eruption of pregnancy next. So this picture is actually one of my patients that I saw while I was preparing this talk, and I was so excited that I didn't even bother to get my shoe out of the picture before taking it. But you can see that it kind of looks like eczema, and it just happens to be eczema that happens during pregnancy. So eczema, atopic dermatitis, those terms are basically used interchangeably among most dermatologists. This is the most common pregnancy dermatosis. And sometimes the woman will have a history of eczema or atopic dermatitis sometime in the past. Either it's something she deals with kind of routinely, or she remembers that she had it when she was a kid or something. But that's only about 20% of the time. About 80% of the time, she has no history of eczema at all. So it's again thought to be that switch from Th1 to Th2 that kind of brings it out. It can be papular. So in dermatology, there are some people who have eczema that just looks a lot more papular. kind of 1 to 2 millimeter folliculocentric widespread papules. So some of the old nomenclature referred to like papular business, and that is now considered to be the papular variant of atopic eruption of pregnancy. So the only particular risk with it is that it suggests that the woman has an eczematous tendency, and that some other things in the future can bring that out as well, such as another pregnancy. So that's the only risk. Otherwise, you treat it like you treat other types of eczema, with topical steroids, maybe with phototherapy. So that's wavelengths of light that we shine on people's skin. We'll talk more about some of the treatments a little bit later. Okay, so those last two things I have seen in person. The next few things I have not. So they're much rarer, I think. They are much rarer. The fact that I haven't seen them also suggests that they're rare. So Pemphigoid gestationis. So this is the disease bullous pemphigoid, which is a known disease in dermatology and is actually, I guess it's uncommon. It's not rare, it's not common, but we definitely see it, usually in older people. And this is bullous pemphigoid that happens during pregnancy. So there are antibodies, specifically IgG1, against this protein called bullous pemphigoid antigen 2, BPAG2, which is part of the scaffolding that holds the skin together, holds the epidermis onto the dermis. So there are antibodies against that, and it makes people super itchy and gives them blisters. This most commonly occurs in the 2nd or 3rd trimester, and this affects the umbilicus. So which disease does not affect the umbilicus? Polymorphic eruption of pregnancy, correct? So this is a nice way to distinguish between the two. And if you were to take a biopsy and do direct immunofluorescence, you would see C3. So unlike the other two, this does have some significant risks. So I use this little baby icon for risks to the baby, and this little pregnant woman icon when it's the risk to the mother. So risks to the baby are that if the mother has pemphigoid gestationis, the baby could be small for gestational age, could be premature, and about 10% of the time those IgG1 antibodies can cross the placenta and affect the baby. So the baby can be born with lesions of bullous pemphigoid. As far as mother is concerned, it turns out there's usually a flare after parturition. So after the baby's born, things are looking good, but about 28 weeks afterward, this can flare for no good reason at all. Also, there's a risk that this recurs with subsequent pregnancies and also with other things that potentially affect hormones like menses and with exogenous hormones that you might give somebody as well, OCPs or hormone replacement therapy and stuff. So if somebody has a history of this, worry. Also, it's associated with Graves' disease, so you might check people's thyroid levels. It's a little harder to treat than some of the others. Topical steroids are usually a good plan if something is itchy on the skin. You can give people systemic steroids, IVIG, plasmapheresis, some heavy-duty stuff, because some of the other things that we might treat patients with this with, if they're not pregnant, are not safe in pregnancy. Here's some trivia about pemphigoid gestationis. I have a graphic here of various types of molar pregnancy. This is for any dermatologists in the audience because I could barely remember what a molar pregnancy is. Moles to us are something very different. But this pemphigoid gestationis is the only pregnancy dermatosis that can affect the newborn skin. The risks to the baby correlate with disease severity, and it can occur with molar pregnancies. And occasionally it's associated with these two alleles, HLA-DR3 and DR4. Trivia. We're going to move on to intrahepatic cholestasis of pregnancy. In my experience, you guys know significantly more about this than we do, so my assumption is that you see it significantly more than we do. So what happens here? So estrogen and progesterone are cholestatic, so they stop the gallbladder from getting rid of all of its bile. And this is the 2nd or 3rd trimester, usually, and it's very itchy. And that's all it is. There's nothing that shows up on the skin, just people are super itchy. They're supposed to be itchier at night, but honestly, just about everything's itchier at night. And I think that's because at night you're not distracted by all the stuff that goes on during the day, so you have nothing to do but lie there and think about how itchy you are. But still, they say this is worse at nighttime, and it's worse in the palms and soles, characteristically. As I said, no primary skin lesions, but there are secondary changes from people scratching the heck out of themselves. So if you look at these legs, you can see pink-brown papulonodules and firm linear plaques, and those are what dermatologists call prurigo nodules, just areas of the skin that have been scratched or picked so much that they have turned into this. I'm sure you guys know some of the diagnostic laboratory criteria. They have to have elevated serum bile acids. Apparently normal bile acid levels are 0 to 6. To make the diagnosis of intrahepatic cholestasis in pregnancy, they have to be over 11. So apparently anywhere between 7 and 11 is considered okay, I guess. Maybe because estrogen and progesterone are cholestatic, so you expect them to rise a little bit. This is a liver issue, so you gotta also check for things like hepatitis C and other causes of cholestasis with appropriate lab work. So there are risks for this one as well, of course, for preterm birth for the baby and sadly for fetal demise. For the pregnant woman, there's a risk of loss of fat-soluble vitamins, which could lead to bleeding. And in dermatology, when I think of bleeding, I think, oh, like if they get a needle stick or something, they'll bleed more. But I know that from your guys' standpoint, bleeding's a much bigger deal because that happens after you give birth, apparently. There's also a risk of recurrence. It's actually fairly high, up to 70% in some studies with subsequent pregnancies. And again, like some of these others, if you do other things that add similar hormones to the woman's body, it can reoccur. So if you take OCPs, there's a risk of recurrence. And also there seems to be some kind of genetic component because there's an increased risk in your family members if you've had this as well. So you treat this, of course, with ursodeoxycholic acid. It seems to be the only thing that works. And apparently there's a recommendation that the woman gets induced at 38 weeks if she hasn't delivered before then, because apparently stillbirths cluster around that time, and getting the baby out reduces that risk. Some trivia about intrahepatic cholestasis of pregnancy. So some people get jaundice, but not that many, 10%. The higher the bile acid levels, the greater the risk to the fetus. If you really think that this is the diagnosis, but the bile acid levels do not support it, just check again. This apparently is more common in South America. Who knew? And then I mentioned a genetic component. So in some patients, they found a mutation in this particular gene, ABCB4. Don't know what it does, but there it is. If you find it on some kind of board exam, you're welcome. Our last one is pustular psoriasis of pregnancy. So psoriasis is a pretty common dermatologic condition. It affects about 1 to 2% of the general public. A particularly bad type of psoriasis is called pustular psoriasis. It also tends to be more of an acute eruption and can occasionally be pretty dangerous and can send people to the hospital. And so pustular psoriasis of pregnancy is probably just pustular psoriasis that happens during pregnancy. And presumably there's something about the pregnant state that tends to induce it in susceptible individuals, associated with decreased calcium levels and also with fever. So one of the thoughts is that pregnancy itself somehow causes decreased calcium, and maybe that leads to psoriasis, specifically pustular psoriasis in this case. So this is risky too. So there's a risk of fetal demise due to placental insufficiency. There's a risk of the stuff that happens when you have hypocalcemia, so tetany and seizures. And as with some of these others, there's a risk that this can recur in subsequent pregnancies. And if it does, it's often earlier in the course of the pregnancy and it tends to be more severe. Bummer. Treat this with topical steroids, just like just about anything else. Cyclosporin is an option. We'll talk more about that in a little bit. And then some biologic medicines like infliximab, which is also known as Remicade. All right, so those are all the pregnancy dermatoses. We're going to talk about treatment in general of the skin and skin stuff during pregnancy. But if anybody has a question about any of those, happy to answer them. Nothing. Lovely. Everything's crystal clear.
Is all psoriasis associated with low calcium, or is that just a specific thing to pustular psoriasis or the pregnancy-related stuff?
My impression is that it's specific to pustular psoriasis.
Cool.
And there are other causes other reasons that people can get low calcium, I believe, can also trigger pustular psoriasis.
Cool, thanks.
It's a pretty nuanced part of psoriasis, so I'm sorry I don't have a better answer. That's just my feeling right now. So people's skin during pregnancy. So of course, you check the pregnancy safety of the medications. I guess we don't have pregnancy categories anymore. I'll trust all of you that that was a good move, but it certainly makes it harder to talk to patients about it. But obviously you do that. And remember the normal, gentle, non-medical stuff you can do to help people's skin. So they can take warm baths. Emollients, moisturizers work best if they're applied to skin that's been recently hydrated in a bath and applied to skin that's dripping wet. So especially if people have eczema or just dry skin that they find really annoying, I tell them to soak in a bath for at least 10 minutes, no soap or anything, and then get out. Don't dry yourself off while you're still dripping wet. Slather yourself with a good moisturizer. My favorite moisturizer is plain old petroleum jelly, Vaseline. Works great. Nobody gets allergic to it. It's super cheap. Good stuff. And then phototherapy. So there's a particular wavelength of light that decreases immune activity in the skin. And dermatologists harness those wavelengths to treat conditions like psoriasis and atopic dermatitis by using machines that produce that specific wavelength of light. It's a safe thing in pregnancy. It's a safe thing in just about anybody, actually. It's really good treatment for some of these things. The main downside is that it's inconvenient. So for people to do it, they have to come to our clinic 3 times a week for at least 3 months probably to see if it really works. But if you have somebody whom you think that might be a good idea, feel free to send them our way. Topical steroids. So topical steroids are thought to be safe, but you should probably limit the amount of high potent or super potent topical steroids you prescribe to a pregnant woman to 300 grams or less during the course of their pregnancy. So as a reminder, super potent topical steroids include beta-methasone dipropionate ointment and clobetasol ointment, and then high potency includes beta-methasone dipropionate and other types of vehicles, beta-methasone valerate, and mometasone ointment. So you don't want to go over 300 grams. And why is that? Well, because of this study. So this was from the JAMA Dermatology, I believe. This was a retrospective cohort study of about 10,000 pregnant women in the United Kingdom. 2,600 were exposed to topical steroids. And the study was performed because people wondered if there was an association with cleft lip and cleft palate in topical steroid exposure, because apparently that's a thing in systemic steroids sometimes. And the good news is they didn't find that, but they did find that if you gave somebody 300 grams or more of potent or very potent topical steroids over the course of their pregnancy, there was an association with low birth weight. The relative risk was 7.7, but the confidence interval was very wide, 1.5 to 40. But still, it was considered significant, of course, because the confidence interval does not include 1. So potentially, your baby's at risk for low birth weight if you use a bunch of potent topical steroids. The good news is there was no association with orofacial cleft, with preterm delivery, with fetal death, with low APGAR score, and with mode of delivery. So topical steroids, pretty good option for the most part. And if you want, you can just stick with triamcinolone 0.1% ointment. That's like the workhorse of dermatology. It's mid-potency, so it should be safe. Give people big tubs of it. Other stuff for the skin and pregnancy. So antihistamines. So they seem to be safe. However, some of them can stimulate uterine contractions in the last month of pregnancy, so the recommendations are to avoid PO antihistamines at that time. And some of the sedating antihistamines can cross into breast milk, and so could potentially sedate the baby if the woman is breastfeeding. So watch out for that, after birth. Okay, systemic steroids. So prednisolone seems to be the best choice if you're trying to treat a pregnant woman's skin condition, because not very much of it gets to the baby. The placenta inactivates it. So compared to mother, baby gets a 1 to 10 ratio. And prednisone, which is normally what we prescribe, is metabolized to prednisolone, so that sounds fine. Beta-methasone and dexamethasone cross the placenta. Though if you are giving people a lot of systemic steroid, especially if it's late in gestation, you want to monitor their fetal growth, I assume with ultrasound. I honestly don't know how you do that, but that sounds likely. And then think about enough of it crossing the placenta that can actually cause adrenal insufficiency in the baby, which especially could be an issue, right after birth. There was also this article that just came out a couple months ago from the JAMA. So I don't know if you guys are already familiar with this article. It seemed like a big deal in the Ob-Gyn world. We actually discussed it on the podcast. This is babies who were exposed to antenatal systemic steroids. If they were born at term, they had an increased risk of behavioral and mental health disorders. So it was a Finnish cohort of a whole bunch of people, like 675,000. About 15,000 were exposed to antenatal steroids. So this was for prematurity concerns. I guess it's somewhat standard of care to give pregnant women systemic steroids, I believe, for lung maturity, but I'm just remembering from medical school, if you're worried about preterm birth. And so that's specifically what this was looking at. So 15,000 of these women got prematurity type systemic steroids, which in their case was betamethasone twice. So 12 milligrams of betamethasone twice, 24 hours apart, and 12 milligrams of betamethasone is about equivalent to 75 milligrams of prednisone. So remember, betamethasone crosses the placenta, whereas prednisone does not. But the babies exposed to the steroids who were born at term had a higher risk of behavioral and mental health disorders with a hazard ratio of 1.3. The babies who were born preterm did not have an increased risk of that stuff compared to unexposed babies who were also born preterm. So how this matters for dermatology is a little tough to say because these were steroids, again, that were basically intended to cross the placenta, right? That's the idea. You get some steroid to the fetus. Whereas the ones that we usually use for the skin don't cross the placenta, but still it suggests that things are not 100% as safe as we think they are. And I guess the upshot for OB is more trying to predict which babies are really going to be born premature and which aren't, which sounds hard. I don't know how you guys do that. So talking more about other systemic immunosuppressants. Cyclosporin, this is a picture of the cyclosporin molecule, seems all right. So there are some studies and some data that I found that suggested that it's a pretty good choice if you got to use a systemic immunosuppressant in pregnancy. There was mixed data on azathioprine, so I wouldn't use it. And then mycophenolate and methotrexate are the other systemic immunosuppressants we usually think about. As I'm sure you guys know, not safe in pregnancy. Mycophenolate causes miscarriages and malformations, and methotrexate, of course, is an abortifacient. Okay, that's basically what I got. So we can go back to our quiz and find the right answers. So, what is the most common cutaneous change in pregnancy? We know that it is areolar hyperpigmentation because we remember that chart that we looked at. What is the best treatment for Striae rubra? Well, we know nothing works for Striae, but remember, these are Striae rubra, so they're red, so you could pick pulse dye laser if you wanted because that can get rid of the red stuff anyways. All right, this dermatosis affects the umbilicus. So it is Pemphigoid gestationis. And which dermatoses can result in fetal demise? Well, several of them can, sadly. Not atopic eruption of pregnancy and not polymorphic eruption of pregnancy. Oh, but I'm going to forget exactly which ones do. I don't remember if it's all three of them or just a couple of them. But basically, intrahepatic cholestasis, pemphigoid gestationis, and pustular psoriasis pregnancy are pretty bad. I believe they're all associated with increased risk of fetal demise. And then the risk of recurrence is all of them, except for polymorphic eruption in pregnancy. So atopic eruption of pregnancy can recur because it suggests the woman has an underlying atopic tendency, and pregnancy again could bring it out. And then we learned that these are probably associated with hormonal shifts in some fashion. So undergoing more hormonal shifts can put people at increased risk for all of those. But you're probably not going to get polymorphic eruption of pregnancy again. Questions?
That was super helpful.
Thanks.
Yeah, that was really helpful. Thank you.
It's fun putting this together. If you guys have questions, of course, your friendly neighborhood dermatologists are always here to help out. Some references there. Happy to share this PowerPoint if anybody wants a copy of it.
Dr. Johnson?
Yeah.
With the pemphigoid, how acute is that? How acutely dangerous is that? If somebody were to show up in your clinic with it, should they be admitted? Should you just call the dermatologist and give them some topical steroids? And
it probably depends on the severity. So And it also depends on how confident we are at the diagnosis. I think unless it's especially mild, I would probably try to manage it in conjunction with dermatology.
Yeah.
Just because we see real
Yeah.
bullous pemphigoid fairly routinely, so we're comfortable with the treatments for it.
Cool. Cool. Thank you.
Not necessarily related to pregnancy, but like especially in the summer, what do you recommend for your patients in terms of doing sunscreen versus like the sun hoodies?
Well, I'm glad you asked. So one of the concerns with sunscreen these days is there is this important study about a year ago in the world of dermatology that says that chemical sunscreens get absorbed into your blood. It doesn't say anything bad happens when they get absorbed into your blood, but we know they do get absorbed into your blood now. So if people are worried about that issue, especially if they're pregnant, first of all, remind them that we don't have any data that says anything bad happens, but we know that zinc and titanium-based sunscreens do not get absorbed into your blood. So if people are worried about that, then stick with sunscreens that contain only zinc or titanium oxide as the active ingredients. In kids, I normally recommend those as well because there's concern that some of the chemical sunscreens can be endocrine disruptors. So you can imagine that a pregnant woman would be concerned about that as well. So again, zinc and titanium if you want to be safe. Otherwise, I don't know that it matters all that much. Probably the sun protective clothing is going to be more effective because it's more reliable and consistent because people put on sunscreen in all kinds of different ways. I've been talking to a number of my patients about sun protective clothing lately because it's summer, and it sounds miserable to wear like a long sleeve shirt in 90-degree heat, but this is clothing that's designed to be a long sleeve shirt worn in 90-degree heat. So it's kind of light and breezy, and it's supposed to have a UPF of 50, which is supposed to be the equivalent of SPF 50. So I think they're a good idea and have a number of them myself.
As far as the treatment for psoriasis goes, I know that you mentioned that oftentimes it's one of the Th1, just like general psoriasis, not the pustular psoriasis that we talked about.
Yeah.
That if patients are on medications for psoriasis outside of pregnancy and they, want to sort of see like how they do off the medications, do you typically recommend that they just discontinue whatever they're on and sort of see how severe their symptoms are and then go from there? Or is there risk that like, if you discontinue your sort of maintenance therapy, your condition will get worse and then it'll be more difficult to control later on? Does that make sense?
It does. I'm just trying to figure out how best to answer. So it's a little bit of a yes and no to both aspects of those questions. So if people have mild enough disease that just topical medicines control it, then I would probably encourage them to continue those, especially because we know if psoriasis goes out of control during pregnancy, it can be pretty bad. Mm-hmm. If people are on like a biologic for their psoriasis, most of the biologics are considered safe in pregnancy, but I understand that a lot of people just kind of want to do the minimum amount necessary while they're pregnant. You could stop them, but if somebody's psoriasis is significant enough that they needed to be on a biologic in the first place, then we worry that it's going to get pretty bad if they stop it. Also, it's important to note that it takes the medicine probably a few months to fully leave somebody's system. So if they discover they're pregnant and they decide to stop the medicine, it's going to take a while for it actually to not be in their body anymore. And then there's this concern that if you sort of start and stop biologics, your body can develop antibodies to them more easily, and then the same medicine might not work as well for you again. I'll admit that I haven't seen convincing data that says that actually happens. I have seen some data that says people develop antibodies, but not that they actually are clinically relevant. And we have so many psoriasis biologics these days that probably they could just switch to something a little different, but that's a potential concern.
Cool. Thank you. That was helpful.
Sure. Other questions? All right, guys. Well, I'm sorry I didn't get to see you in person. It's always fun to actually come down to the department and see my colleagues and other divisions. But feel free to drop us a line if we can do anything for you. And thanks for taking care of all of our pregnant people.
Thank you. Appreciate it.